Thank you very much, and good morning to everybody. First of all, a big thank you to Team IDEC for inviting all of us here for this wonderful event and bringing us back to the classrooms and learning of classroom. It's indeed a wonderful feeling to be here back. So, Archana has already set the ball rolling and she's made my task much easier by giving the foundation of what we are doing today. We are going to take you through to a journey of a type 1 diabetic patient from the time the patient is diagnosed to its various stages, from the time the child comes to us in the clinic, what are the important aspects that we need to be caring about, we need to be talking about to the patient, especially when it gets diagnosed for the first time, when it comes to the clinic for the first time, what are the points which we need to put emphasis on. And then subsequently, Dakshata and Alka are going to take you through to the journey of the child through different stages, right from insulin therapy to adolescence and marriage and other problems that a child may go through. So, so type 1 diabetes is a unique problem or unique burden is what has been quoted. It's an interplay basically of adjusting various complex regimens. It could be behavioral, it could be social modifications, and there is a need of considerable knowledge and skill that will help a patient or that will help a child to navigate through the tough journey of hypo and hyperglycemias. Our goal is primarily to make sure that the child reaches or the desired goal in the best possible way without basically facing the burden or without having the troubles of hypo and hyperglycemias. So Swati is a happy girl, 12 years of age, living in a semi-urban town, studying in 8th standard. His father is a clerk and mother works in a factory. Has 2 siblings, older brother and a younger sister. No past medical history of anything in the family. Gets diagnosed primarily for the first time with type 1 diabetes, comes to us with characteristically high sugars, with ketones, and with classical symptoms that have been there for some period of time. We all know that what we are looking for, the symptoms primarily in a patient with type 1 diabetes normally presents to us sometimes in an acute stage with diabetic ketoacidosis and severe weight loss and dehydration, vomiting, polyuria, polydipsia is there. Sometimes nowadays we are seeing lot of cases, younger and younger people getting detected and maybe coming at a much earlier stage to us also, may not yet go to a stage of diabetic ketoacidosis but may come much earlier. They may be in a stage of antibodies positive but still not reach the stage 2 or stage 3 of type 1 diabetes. So we need to be careful about the symptoms that basically are and we should be talking about especially the symptoms to these families also. We look at certain investigations when a patient comes to us for the first time. Of course, the fasting, postprandial sugars and HbA1c are the gold standard that we look at. Mainly GAD antibodies, islet antigen 2 and zinc transporter are the 3 main antibodies that we are looking at, which will give us a confirmation of a patient with type 1 diabetes, especially for an age group where we are seeing more and more younger people with type 2 diabetes also getting diagnosed. It becomes important for us to distinguish very clearly that whether the child is a type 1 or a type 2. So GAD, islet antigen 2 and zinc transporter are the 3 antibodies or the 3 markers that we are always looking for. C-peptide has its own fallacies. Yes, C-peptide helps us to find out the insulin reserve in a person, but initially when a child gets diagnosed with diabetes or any person with diabetes, the C-peptide levels are usually lower and we don't rely only on that level initially, and we need to give some time after the therapy being started to see again whether the C-peptide has gone up or no. So if you look at the ADA recommendations for screening particularly, now a child can get diagnosed with type 1 diabetes, but it is also important, Dr. Prasanna Kumar also mentioned in his talk earlier, that it is important for us to detect these cases also as early as possible. Lot of research is going on, something to prevent type 1 diabetes in the future. And for that, screening an individual for type 1 diabetes becomes important. American Diabetes Association recommendations clearly say that screening for type 1 diabetes risk should have a panel or should be tested mainly with insulin autoantibodies is what has been recommended. When persistence of autoantibodies is a risk factor for clinical diabetes and may serve as an indication for intervention in the future trials. There are different stages of type 1 diabetes actually. If you see, there is a stage 0, you can say, or the pre-diabetes stage where a child may have antibodies positive, but is still asymptomatic, may not have the sugars being high, and you may just detect them at a very, very early stage. Stage 1 is a stage where the patient or the child is antibodies positive and then gradually starts developing dysglycemia. In the next stage, there is an abnormality in the blood glucose level, earlier seen impaired fasting glucose or an IGT is seen in the earlier markers, and or an A1C may be somewhere between 5.8 to 6.4. And then comes the stage 3 where the child becomes symptomatic, develops symptoms, the blood sugar is high, A1C crosses 6.4, 6.5. So it is important for us to detect a child much earlier before they progress to a stage 2 and stage 3. After somebody is diagnosed with this, it is also important for us to clearly give a diagnosis, and at an age where Swati is at 12 or 13 years of age, it could be more or less type, we have to distinguish it from a type 1 and a young type 2 also. At a slightly older age, there can be monogenic diabetes also, which could be presenting younger people, and so there are clearly signs which tells us what is typically type 1 and what is not type 1. Presence of ketoacidosis, presence of antibodies clearly distinguish these individuals from type 2 and monogenic diabetes mainly. This is what Arjuna also showed in a slide. The center of goal or center of therapy is always education for a family and for a child with type 1 diabetes. When they are sitting in front of us in our clinic, we need to be talking to them about various aspects in the very first visit. It should start with monitoring, it should start with exercise, nutrition counseling, emergency care needs to be taught to them well, talking to them about insulin therapy. So the central basis for treating a child with type 1 diabetes is always education. It is not a prescription, it is not something that you write an insulin therapy and just tell the patient to go. That does not work. So it requires a dedicated approach, it requires a team approach, it requires time for a doctor to give to a type 1 patient. A busy OPD with 20 patients sitting outside where you want to finish it fast is not the right kind of atmosphere where you'll be treating a child with type 1 diabetes. A team comprising of educators, counselors, leaders, particularly with type 1 diabetes, becomes very important. When somebody with type 1 diabetes talks to a child with type 1 diabetes, the impact is much, much stronger. A nutritionist and a coach which would guide the entire process. So following diagnosis, the major problem that comes to a child and to a family is again psychological. The major crisis that impacts, which immediately affects is the belief, the fear of the disease, the shock, the disbelief that is there, denial is there. Many times we see the patients and the relatives telling us that this is just a one-off report. I don't think it is true. It could just be because of eating something for a few days that we had festivals or we had marriages, etc., because of which this could be there. These kind of myths, this kind of anxiety is always there, and we need to talk it out to the family. We need to talk to the patient and make them understand what the true picture is. A new family is always vulnerable and traumatized. We need to be talking about these various aspects, mainly busting the myths around type 1 diabetes. In today's times, with social media and with so many things being out there, every day some new comment comes and we have to make them understand what is true and what is not. We need to talk about insulin always, which becomes very, very important. Once a patient, we start on insulin for the first time, they may go into an honeymoon phase after a certain period of time, and that's where the requirement of insulin again comes down. And that is the time when many people make this mistake that they stop insulin completely. We need to tell them from the very first visit that insulin will be required for the lifetime, and insulin will be required on each and every day, irrespective of the dosage or even if the dosage comes down. Addressing the honeymoon phase, warning against alternate therapy. So many times we see these problems that patients after being stabilized on insulin suddenly are away, they do not follow up and they come back in ketoacidosis because somebody has advised them some alternate therapy and they'll end up in a trouble. Perfecting insulin and monitoring techniques is important. Learning to manage hypoglycemia is very, very important. Hypoglycemia is again a big fear, and one episode of hypoglycemia literally shakes the child, literally shakes up the family members also. We look for comorbidities which could be there. Sometimes a patient is diagnosed late, sometimes a comorbidity may already be setting in, so we need to again assess for that. Following diagnosis, the other important aspect is to accept the disease, accept the problem. Many times that is the biggest, again, burden or hurdle that we have to convince the patient that what is right for this. When a doctor prescribes insulin therapy, the first reaction is always no, why me, why should I take insulin, and so on. Patients with type 1 diabetes and their families should be again accustomed or should be exposed to various team, as I told you, a psychologist, a nursing staff, social workers, schooling. We need to give special advice to the school authorities. We need to give them, we need to adjust the school timings, etc. also for this. So insulin therapy becomes the first thing that we should be talking about when the patient, when they visit us for the first time. Remove the cobwebs of insulin from their mind again. Talk to them about insulin technique, the right way to do it, because faulty insulin technique is one of the major reason because of which they don't reach the desired goal, and sometimes they'll end up with again lipohypertrophy, lipodystrophies, and diabetic ketoacidosis. The site rotation becomes very important again to prevent these things. Storage of insulin, especially in interiors, in smaller towns, sometimes where refrigerators are not there, we need to be guiding them and giving them these advices. Keeping the gap before insulin again is very important. Many type 1 patients are, or most of them are on human insulin still, and they need that 30 minutes of gap between the meals and the insulin, which needs to be emphasized upon. We need to explain them the type and action profile of each insulin, because after going out from your clinic, most of them will be managing their diabetes, managing their insulin doses on their own. And if they do not know what kind of action profiles their insulin is, or which insulin is working for how many hours, they will not be able to do this adjustment on their own. This is one of the study done by Fitter, which showed that which clearly showed the ignorance for patients who were taking insulin with type 1 diabetes, and most of them did not have any idea regarding so many factors like depth of injection, length of the needle, how long to wait, or how to pinch the skin fold, etc. And these are very small things which needs to be emphasized upon. Insulin regimens, of course, Alka will be covering, but basically for any type 1 diabetic patient, basal bolus is what has been recommended and what should be emphasized upon. Premix insulin should be discouraged and should be clearly told no, and more, even if for the convenience aspect. And all patients with type 1 diabetes have to be on 4 doses or basal bolus regimen, where we are giving 3 doses of shorter acting insulin or a rapid acting analog and an NPH twice a day, or an NPH at night, or a longer acting analog at night time or bedtime. The next aspect which comes along with insulin therapy is monitoring. Any patient on insulin therapy has to be told that self-monitoring or SMBG again goes hand in hand with insulin therapy. It is important because primarily it helps us to achieve the desired glycemic control. It engages, educates, and empowers the patient, thereby reinforcing the behavior of the patient. We need to make them understand that SMBG is going to tell us where they stand. It is just by taking insulin is not the only solution. We need to understand or explain the child in that language, that if the child is studying and appearing for an exam, the results is what he's waiting for. Similarly, an SMBG is something which is going to give him the results of his the exercise that he's doing every day. Tell the patient and the relatives the importance of SMBG. Talk to them about CGM also in today's time, because every patient needs to be ignorant or needs to know about CGM also. Tell them about various other tests that they need to do, like HbA1c, urine ketone monitoring, microalbuminuria, and other parameters that need to be evaluated, like retinopathy evaluation. Again, SMBG requires certain important tips to be told, storage of the trips, the exact technique of SMBG to be done. Record keeping is important. Nowadays, we have mobiles and datas and everywhere how the SMBGs or logbooks can be maintained in today's time. And child, in fact, the younger people or the adolescent are very, very tech savvy and they love to do that and they keep doing that on their own also when we are looking at that. So simple charting of monitoring and logging is what is advisable. Tell them to which time of the day we need to check the blood sugars, mainly 7-day profile or 7 different times of the day, and tell them, give them a chart of which, and it's easy. We don't tell them to do the test all 7 times in a day. Of course, it's not practical enough, but give them an idea that they can do any 1 or 2 tests in a day at different timings, and that's how a logbook can be maintained. The other important aspect comes again, as I told you about CGM. It is something which is gradually becoming cost effective in our country slowly and slowly. So any patient who can afford CGM can preferably do that also, and it is going to give us a larger picture regarding the glycemic control. Nutrition is again an important aspect that has to be spoken about in the first visit and at every visit whenever the patient is coming to us. Remove the myths from their mind regarding nutrition, the myths that are surrounding diet. Carbohydrate counting is the essential therapy or is the essential way to go in a patient with type 1 diabetes. Talk to them about in-between snacks, talk to them about bedtime snacks, talk to them about certain religious diet, especially during fasting, etc., which they should not be doing or or how they should be eating. Meal planning becomes important per se, and it's important that they adhere to the meal plan and snack at adequate timings, especially coinciding with the insulin. Physical activity, especially in younger and adolescent, again, those who are exercising, those who are doing their routine, it becomes important. Tell them how the blood sugar levels can fluctuate before and after exercise. Teach them about the insulin dosage, especially the shorter acting insulin, how they can adjust the dose before doing an exercise or after exercise to prevent hypoglycemia. And mainly that is what is important again for a patient who is exercising regularly. Hypoglycemia, the symptoms of hypoglycemia needs to be told to them. Important is to explain them the rule of 15 when they get an episode of hypoglycemia, how to correct them without any help which is there, which if help is not achieved immediately, they should be ready enough to tackle hypoglycemia at home. A sick day regimen is something again which needs to be spoken to them about what they should be doing, and taking adequate fluids, checking their urine ketones on that particular day, adequate insulin dosage which needs to be given, or an extra amount of insulin which needs to be taken if the sugars are high for more than a certain period of time, and to decide when hospitalization is needed is what again becomes very important. So education and tool is something which needs to be told about. There are different ways again to talk about. We need to assess how receptive each family is or each person or each child is, and then talk to them about different aspects of education, like from basic monitoring to CGM to pumps, etc., which needs to be told in gradual visits every time. Peer group activity becomes important. A child, when they realizes that he is not alone or he or she is not alone with this kind of disease, overall the social acceptance becomes much better, psychological acceptance becomes much better. Talk to them about people who have had this disease and how they have done well in the past. Explain them or give them examples of leaders, give them examples of celebrities who are doing it or who are already with type 1 diabetes, and talk to and explain them how they have achieved in their life in spite of having this problem, and overall it motivates them to do better. So way back in 1933, Jocelyn had said that true, it is a fight, but there is a pleasure in the struggle. Victory comes to the courageous. Look upon a type 1 diabetic as a charioteer, and a chariot as drawn by the 3 steeds, mainly diet, exercise, and insulin. It takes skill to ride 1 horse, intelligence to manage 2, but a very good teamster who can get all the 3 together. Because it was in 1933, I think in today's time we can add 2 more horses to this. It is education and it is monitoring, which would overall help a type 1 diabetes to ride the chariot much better. Thank you.